welcome to the ACSD webinar for May 21st, 2025. This was originally planned to be a QI webinar. We did not have a speaker for today, so we decided to make this a reporting webinar since everyone just received their Harvest 1 reports. So thank you for joining. On the call with me today, I have Emily Conrad from the STS, Leanne Jones, Carole Krohn, Banu Yati, Sydney Clinton, and Melinda Offer. We're going to start out with some important dates, just a couple updates, and then I am going to turn the program over to Carole Krohn, and she will review your most recent reports. So for important dates, today is May 21st, our what is now a monthly webinar. Harvest close. So Harvest 2 closes on Friday, May 23rd. This is surgery dates April 1st of 2022 through March 31st of 2025. The opt-out date for Harvest 2 is next week on Tuesday, May the 27th. Then on June the 4th, we will have our monthly webinar at our regular time, 3 Eastern, 2 Central. And then this is not correct. May 27th is not an additional Harvest opt-out deadline. May 27th is our next QI webinar. Sorry for that error there. Here is the complete Harvest schedule for the year. And again, Harvest 2 closes on Friday. And then you can see Harvest 3 will be coming up in August and Harvest 4 coming up for November. Remember that each harvest period is based on a 36-month window, and that the Harvest close submission time occurs at 11:59 p.m. Eastern on the date that is on the schedule. Just wanted to remind you of our quality improvement series webinars. Our next one, again, is June the 18th at 3 p.m. We need presenters, and we want to hear from you. So if you have a quality improvement project that is going on at your facility and would like to present that to us so that we all can learn from you, just reach out to me, Nancy Honeycutt. So just some brief updates. As you know, the Harvest 1 reports were released last week. This update included the multi-procedural composite. It also included updates to the initial ventilation hours calculation and the new onset atrial fibrillation calculation. The update to the initial ventilation hours including patients extubated in the OR into that calculation. And then for new onset atrial fibrillation, that calculation excludes patients with a history of atrial fib. Also updated on the IQVIA platform in the library is the Harvest 1 Composite Quality Rating Summary. So just a reminder, AQO 2025 is going to take place September 25th and 26th in San Antonio, Texas. We'll be at the Grand Hyatt San Antonio Riverwalk. The Intermax PDMax folks will meet on Tuesday, September 23rd, which will be virtual only. Then we have congenital and thoracic meeting on Thursday, September 25th. And for adult cardiac, we will gather on Friday, September the 26th. No updates as far as cost and registration. Emily, do you have anything that you want to add?
I believe that we'll be able to post registration next week. We're finalizing that right now with our meetings team and our marketing team. So I believe that'll be coming next week. And then just as a reminder, the abstract deadline is June 2nd for poster presentations and then possibly oral presentations. So we look forward to receiving your abstracts.
Awesome. Thanks, Emily. And I just wanted to remind everyone of our additional networking opportunities. Our STS Data Managers Facebook group is up to 501 members. So be sure to check that out. You can scan that QR code for the link to the Facebook group. And then we have the STS Data Manager Collaborative and the STS regional groups as additional networking opportunities. The Data Manager Collaborative pairs data managers who are seeking advice related to data abstraction, and the regional group is also a good way to collaborate with peer-to-peer support and non-clinical guidance related to abstraction across our specific regions. You can find more information about both of those on the STS website under Resources for Data Managers. Oops, went too far there. All right, so I'm done with updates. At this time, I'm going to turn it over to Carole.
Thanks, Nancy. Hi,
Well,
everybody.
reports.
Thank you. Want to take the questions in the chat box first or in the Q&A first so we don't.
We can.
Okay. I think, did you already provide Nancy with AQO detail update?
Yeah, we talked about AQO. No further details really to share. We are working on the program. More to come on that later.
Okay.
And then, what is this? Do we still code post-op AFib if the patient has pre-op AFib? You still code AFib the exact same way that you have in the past. The change that was released with the new reports is a calculation that IQVIA does on your benchmark report. So please continue to code post-op AFib in the same way that we have laid out for you in the training manual.
Okay, thanks, Nancy. Okay. All right, we're going to get into, I'm going to share my screen. Hi, everybody. Thanks for joining. Which screen do you see?
Email.
Okay. They switched my screens on me. So hold on. Please hold. How about now?
Nothing now. Oh, here we go. I see your community page.
All right, awesome. Thanks, everybody. So today we're going to go over the Harvest 1 report and talk about some tips and tricks on how to use this report or how to explain it to your surgeons or those who may be interested in how your hospital is performing in cardiac surgery at the STS database. Of course, the first page we have is the community page. This is just the high-level overview of performance at your facility that is intended. You could take screenshots of these widgets on here to disseminate them or use them in PowerPoint slides for your meetings. Just Harvest 1 is going to be the one to the left, and we have the new multi-procedural overall star rating included in here. And then you have your bar charts, and each of the procedure types are listed here. Multi-procedural has been added here as well. And right now we have the 4 high resource utilization endpoints of ICU time, postoperative length of stay, postoperative total vent hours, and total blood product usage. And it shows your site data. These are for full year since we're looking at Harvest 1. And as you remember, Harvest 1 of 2025 includes data from all of 2022, all of 2023, and all of 2024. So these are full years. And then you have the STS 2024 benchmark here. So you can use that as a comparator. And the way to read these results, you have your mean. This is for ICU time, mean, median, 25th and 75th percentile. Your site scores are to the left of the red, which is the red, or this dark red color is the STS benchmark. These are ICU times. So and you can pop these reports out or these screenshots out a little bit by clicking on the double arrow. So these again would make nice PowerPoint slides if you took a snippet of that. So what this is showing me for my site, my ICU times have been below the STS average. My mean has been below, my median has been a little bit above, 25th percentile is higher than the STS, and 75th is lower than the STS. 75th percentile is I have to look at it, I think it's the highest end, and then 25th is the lowest end of, if you think of your ICU times on a continuum, then you would break it into your median, which is your middle value. Your 25th percentile would be down towards the left, and then your 75th percentile would be higher ICU times, and then your mean is just an average of your times. And then to go back here, so this is just really high level overview of how to read these reports. Post-op vent hours is reported similarly. This is looking at how long your patients were intubated postoperatively, and then total blood product usage, which includes intra and post-op blood products. We report out red blood cell, the cryoprecipitate, FFP or fresh frozen plasma, and one or more units of platelets. And then we can have a total blood product use, which combines all of those. And then this is just for the current, this next widget down here is for the current harvest. So this is reflecting the dates set for the harvest that close on Friday, which is Harvest 2, and it includes data from April 1st of 2022 through March 31st of 2025. And we're going to talk about this one. I don't think we're talking about it today. I think we've already talked about this, but we'll review it again prior to Harvest 3 close, so you can help get prepared for that. So from the community page, I'm going to go over to the risk adjusted dashboards. Let me see if I can move this. I don't know if you could see that or not, but that was the black bar, the Zoom bar. I'm going to go down here to the risk adjusted reports, and I've already opened it up. When you go to risk adjusted reports, the most recent report is the report listed first, and this is the Harvest 1 2025 time frame. So January 1st, 2022 through December 31st, 2024. I already opened it, so we didn't have to wait for it to take a long time to load. So that is this report. You'll see the period ending December 21st, and then you have the 6 different sections. And if you participate in anesthesia, you would see a 7th section to the right of the benchmarked reports, which would be related to anesthesia. To start with, because this is a star rating period, we have star ratings for Harvest 1 and 3. This is a star rating period that, so that means that the quality ratings and quality rating detail sections will be updated with your updated stars. And you'll see here we added in multi-procedural. I'm going to start with the cabbage. Hopefully it opens. There it goes. And so this site had a nice range here for the cabbage. So that would be good to see these. I just got lucky actually by picking this site to go through. So we'll start with explaining, this is the star rating page. You will have your domain, then we're in the cabbage section. So up at the top here, it says this is the cabbage composite quality rating, your site's number, and then the time frame. And it's going to have, again, this is related to cabbage. It has the domains that we calculate under the cabbage composite, which includes the overall composite, which is a combination of mortality and morbidity. For cabbage, we also report out mortality and morbidity separately for star ratings. And we report out 2 process measures, the use of internal mammary and the medication. The other composites you'll see likely, I think we just have the overall, and I don't know if we have a separate mortality or not, but we'll go into there. You won't see 5 different rows of star ratings for those other ones. Cabbage is the one that has separate models that we do star rating reporting on. So overall, the site received 2-star, which is a combination of these four pieces of the composite: the mortality, morbidity, internal mammary usage, and medications. 2-star, the site score was 97.66. Their confidence interval is 97.5 to 98.7. And when we look at confidence intervals, it's a 95% confidence interval. So we're fairly certain that your site score is 97.66, but there's a confidence interval that says that the site score could actually fall somewhere between 97.05 and 98.17. The larger, the sites that perform many cases are going to have smaller confidence intervals, because STS is, and the way risk modeling works is that you're able to better determine performance of a site. For this example would be a site, you're better to understand performance of a site by examining more cases from that site. So sites that have more cases, we're better to say repeatedly how that site is performing, versus when we look at their observed to expected rates, and we'll get more into observed to expected rates in just a minute, versus smaller sites where you might only have, you have a smaller number of cases. It's harder to predict or to observe how that site really is performing. So you're going to have a wider confidence interval for the smaller sites. The reason that's important when we look at star ratings is because the smaller confidence intervals have the smaller confidence intervals and have a better, you're better able to estimate the site's performance, which means there's less likelihood for the sites, for the STS score to fall within this confidence interval range performed at the sites, because what that indicates is that if the STS score is falling somewhere within the confidence interval, then the site's performing as expected. So where you tighten up the confidence intervals, there's less of a chance for the STS score to fall within that confidence interval, making it either a 1 or a 3-star. So volume plays a part in determining if a site is a 1, a 2, or a 3-star program. So just keep that in mind. We have the participant score, which is 97.66. We have the confidence interval of 97.05 through 98.17. We're saying the sites, we're 95% confident the site scores someone in here. We're pretty certain it's this 97.66. The STS score is 97.05. And you can see here that that is right at the lower end of the STS of the site's 95% confidence interval. So when you take this 97.55, and we're going to scroll down here, you'll see it's right at the lower end of the site's confidence interval. Hold on one second, and I'll see if I can make this bigger. I can make it bigger, but it's not pretty. Let me see if I can make it smaller again. Hold on. Oh, geez. There we go. How's that? Whoops. All right. So I don't know why it's so light right now, but there we go. So if we're looking at the overall, we said the site is performing as a 2-star hospital. This is the site score, this black line here. This would be your score. This is your 95% confidence interval. It does contain, just at the very end here, it does contain the STS score, making this a two-star program. But you can see how close this site is to actually being a 3-star program. Because if their 95% confidence interval, the lowest range of the confidence interval is greater than the STS score, that would make them a 3-star site. Right? So you have your 95% confidence interval, you have your highest end of the 95% confidence interval, your lowest end of the 95% confidence interval. The STS score is at the very low end here, still making them a 2-star site. But if just for example, if the STS score was actually here in the light blue, the site would be performing better than the STS, even considering the 95% confidence interval. So what we look at when we determine the star rating or the star rating is how this site is performing in relation to the STS overall. It's not against other sites. It's not a comparison against other sites. It's about that site's performance, including the risk of the cases, and then the outcomes of the patients against the STS cohort as a whole. So all of the hospitals in the cohort, all of the hospitals within the STS analysis make up the STS score. So this site is performing, although slightly better, their 95% confidence interval due to the way the risk modelings perform is showing that they're still performing as expected because the STS score is falling within their bottom end of the confidence interval. So when we get back up to 3 stars, this is a good example for a 3-star program. In their absence of morbidity, the site score is 93.89. Here is their confidence interval. It's 92.49 to 95.14. The STS score is 90.82. So it's going to be, if you put it on a continuum, it's going to be to the left of the lowest score of the site's, the lowest value of the site's 95% confidence interval. This site is a 3-star because they're performing better. Even looking at the confidence interval, lowest end of the confidence interval is performing better than the STS score. And then we can go down here and see, let's see if we can scoot this. I think we were at, there we go. So the whole background range, this light blue is the overall STS min to max. So if you're looking for what's happening nationally and you're looking for a minimum to maximum absence of morbidity, you have sites scoring as high as whatever this value is. I can't see, but it's up above. And then however low this value is on this end, just below probably around 68% or so. So that's the absence of morbidity range for the STS. And then like we talked about earlier, the darker blue here is the site's 95% confidence interval. The site score is this black line. And then the STS score is this red dotted line. So the STS score is 90.82 for absence of morbidity. The site score is 93.89, but their confidence, considering their confidence interval, if I can get it to pop up. Hold on, I got problems with my clicker. The site's confidence interval, the lowest range of the site's confidence interval, which would be right here, is higher than the STS score, making this site a 3-star site for absence of morbidity. If we go back up and look at the 1-star site, you're going to see that the site's highest end of their confidence interval is lower than the STS score, making it a 1-star site. So you take your, look at, in essence, look at your confidence interval, see where the STS score is, and you'd be able to determine if you're performing better or worse, and how close you are to performing at the next level either higher or lower. So for the medications, this site was at a 92.10%. Confidence interval ranged from 90.51 to 93.57. The STS score is 95.72. It is not falling. The STS score is not falling within the 95% confidence interval. So to me, that's going to be either a 1 or a 3-star program. And I know it's a 1-star program because the STS score is higher than the highest range of their confidence interval. And we'll go back down here and let's see if we can get this, there we go, to come back up. So you can see a wide range here between medications is a wide range. We have 100. It looks like it goes from 100 to something very low down here on the other end, just over 20%. Some sites apparently are not very good with their medication administration. It's something that they likely need to improve upon. So you can see again, the light blue is the range of values for the STS. The site's 95% confidence interval, the site score are here. The STS's score is here. So what this tells me on a national level is that even though we have some very low performing sites, around 20%, making that market 20%, overall, most of the sites at the STS are performing pretty well because we have a value of almost 96% for medication administration. Of course, it could be better, but it's still pretty, not as bad as being, right in the middle of 100 to 20%. So anyway, this site's score, the highest range of this site's score is lower than the STS score, making this a 1-site program for cabbage medications. All that being said, you can see the overall score is not just a combination of, like you don't just wrap all of your star ratings up and average it out and come up with a score for your overall. It actually takes into account different things. You have to remember the overall. You should remember the overall is a different type of cohort than each of these individual measures. So you might have different patients that fall into your internal mammary use measure that would be excluded, or that would be excluded from your internal mammary, but would be included in an overall when you're looking at the other 3 measures. So it's not just an average. There's more information on this in the national report overview posted on the IQVIA platform. But they're calculated separately. Overall star rating is not an average of your of the various composites of the various measures that go into the overall. It's a different separate calculation. The other main points is if I'm looking to see how close or how far I am from achieving the next star rating of either going up to a 3-star or dropping down to a 2 or a 1-star, or going from a 1 to a 2-star, I can see how STS is performing, where that STS score falls in relation to my site's confidence interval, and perhaps overall there's nothing specific here that's telling me that any of the other measures that go into overall are close. So this could be, maybe I want to, just verify my documentation, make sure I'm collecting all my risk model variables, and check on my various morbidity endpoints. That is where absence of morbidity, I was a 3-star, so I'm probably doing pretty good there, but medications was a 1-star. So maybe I want to, even though it's not weighted the same as morbidity, when you look at the cabbage composite, maybe I still want to check out my medications and see if I can improve dictation or charting on those, or adhering to the guidelines to get credit for those patients. So that's cabbage. And then let's go back here.
Carol,
Yeah,
can you go back to that? Sorry,
yeah,
where you were. Can you explain again how volume affects the confidence interval?
sure. So the way volume works, and think about it like this, and this is odds ratio. If we're going to talk about odds ratio, this is probably a better example for odds ratio. But when you have, say you're rolling a dice and you roll it 5 times and you only, maybe you end up with like 2 1s, 2 2s, and a 3, and you never get a 5 or a 6. You have better, maybe I'm going off course here, but essentially what it's saying is the more times something occurs at a site, so the more procedures that you have happen, or the more times you roll a dice, the better we are to understand how your hospital is performing with a increased degree of certainty. The less time something happens, or the less time a hospital, less number of patients that a hospital has for us to try to understand, the less degree of certainty we have in that hospital, the hospital's performance. So the more cases that you have, the increased degree of certainty, and it shortens your confidence interval. Your confidence interval is primarily based off of volume. So the less volume you have, the wider your confidence interval, because we can't make a good assessment of STS in the analytics. They can't make a good assessment of the performance at your hospital. Where we get more cases in, we have a better degree of certainty of how your hospital is performing. So your confidence interval shrinks. Think of confidence as in, we also refer to it as credible interval. So how credible are you at performing something and not having bad outcomes occur? So how credible are you? What's the confidence we have in the performance of your hospital? All those things increase with the number of cases you have. So it gives you a better opportunity when your confidence intervals shrink or have a higher volume. It gives you a better likelihood of achieving 1 or 3 stars, but it's not the only thing that goes into that. You can perform a lot of hospitals, but you could still have a lot of really bad outcomes, and your observed to expected ratios are going to be greater than 1. And we're going to get into that in a few seconds. But so just because you have a lot of cases doesn't guarantee that you're going to be a 2 or a 3-star program, but we'll have a better idea if you're of how your hospital is performing. So I hope did that help, Nancy?
Yes, yes.
Okay. All right. So we did that one. Now we're going to go over here to cabbage quality ratings. That was actually the report I wanted to spend most of the time on, in addition to the report I'll go to next after this one. So the cabbage composite quality ratings, this is the number of, we have the time frame, the domain. So we have the mortality, morbidity, internal memory, and medications. We don't have the overall domain for overall. We don't have an overall domain. So we have these 4 domains. Each of the time period is listed here. This represents the 3 or 36 months of data that are in the analysis, and then the number of eligible procedures. It will not always be the same. So perhaps for this site, it looks like their eligible procedures for mortality were 1,192. Same with morbidity. Their internal memory eligible population was 1,180. They likely had 12 patients that met criteria for not having to use the IMA. And then medication usage is 1,192. So these numbers can fluctuate. So from mortality, and kind of what I can see here, just because my mortality has the same eligible population as my morbidity, I didn't have any patients die in the OR, because the more patients that die in the OR are going to be excluded from the morbidity endpoint, because they would never have any bad morbidities happen to them since they had already died in the OR. So, and that's just quick what I see there. So my mortality, I had 20 patients that died. This report you can drill down on, but there's other places to get this information too. This is just a nice report to show you what was going into the risk model for the star rating analysis. Any morbidity, this is the number of any patient that had a morbidity. It could be 1 or any. So 64 total patients out of the 1,192 had a morbidity. I have the individual morbidities listed here. We're looking to reorder these so it reads a little bit better, but when you see the word and then only at the end, This means patients who only had a cerebrovascular accident or only had deep sternal wound infection, only had prolonged ventilation, only had renal failure, or only had a cardiac reoperation. It does not, these counts, if the patient had multiple of these morbidities, they're not going to be counted in these individual only rows. They would be included in the multiple morbidities. So for patients who say had a CVA, a stroke, and ended up being vented for a long time, you're going to find them in the multiple morbidities count instead of the individual counts. The reason this report demonstrates that is because that is how the risk model works. It's a one or any. I'm sorry, any or none. So you either have any of these, they all count the same, one or any, one or more count the same in the risk modeling, or you have none. So that's how those work, internal mammary, and then you could drill down to see these cases, but I like the other benchmark report. I think that's where you drill down. I like that a little bit better. Internal mammary usage, failure to prescribe all eligible NQF endorsement medications, and then it breaks down similar to how the morbidities are broken down. You have the individual medications, and then you have multiple medications. So they missed 65 patients for preoperative beta blocker only. And then they had 6 other patients that had multiple medications missed. That's actually pretty high. That's why they got a 1 star, but they had, what do you call it? Some of these multiple medication patients could include beta blockers along with other medications. So that's just an easy way to look at that one. And then the report I want to spend a little bit of additional time on. I know we have 20 minutes. So I'll try to get through this in about 5 minutes and then go to the benchmark report and then leave time for questions. This is the risk adjusted data. And so what you're going to find on the CABG risk adjusted data is in hospital, operative, and then each of the endpoints and a combination for major complication or mortality. And then your long length of stay, short length of stay, total length of stay, and post-procedure length of stay adjusted rates. So this is kind of a longitudinal look at how your site's been performing. We use the ODE, which is your observed to expected rate for analysis when we do the risk star modeling and things like that. We also report out odds ratios. Both of these are legitimate methods to report out performance. They say that odds ratio has might be a little bit better for smaller volume sites. So if you're a smaller volume site, you can look at that and see if it's that usually has a little bit better at adjusting or predicting performance, calculating performance for sites with smaller volume versus the O to E, where having larger volumes gives you a better observed to expected ratio. Not a ratio, but it gives you a better, I guess, more clarity on how you're performing looking at your observed to expected rates. So if we're just going to look in hospital mortality, our patients that die in the hospital within, it could be any time within the initial acute care stay. Operative mortality includes that subset of in-hospital mortalities, but also patients who die within 30 days if discharged from the hospital prior to 30 days. So operative mortality is the main endpoint that we look at. In hospital is a subset of operative mortality. When you're looking at operative mortality, we're going to focus on the ODE because I can explain that one the best. That's your observed to expected rate. And then you'll see that you have the 3 12-month periods listed up here. On Harvest 3 reports, this gets a little janky because you have a partial year at the beginning, at the end, and then 2 full years in the middle. I like Harvest 1 because it gives you a full picture of complete 12 months worth of data. And it's a good indicator of your performance over time. So if we're looking at operative mortality, from previous discussions we've had, and I'll just do a brief reminder, your O to E is your observed rate to your expected rate, and observed rates of what is what's actually happened. Your expected rate is the determined rate that according to the risk factors that have the patient enter the operating room, what's expected to happen to that patient, and if that, so that's your expected rate. An observed to expected rate of 1 is as expected. That means that what was observed is what was expected, and it occurred, and that's what we were thinking was going to happen. No significant variance in where we thought the patient was going to end up. Having an observed rate higher than an expected rate means that more bad things happen to the patient than what we were expecting. So perhaps the patient was completely healthy, except that they had, a leaky aortic valve for whatever reason, maybe, whatever, maybe they weren't completely healthy, but they had something going on with them. But otherwise, they didn't have too many bad comorbidities happening. Maybe they weren't diabetic, weren't hypertensive, never smoked, or, super fit people. So they're expected for something bad to happen is pretty low. But this patient comes out of surgery, they have a really rough post-operative course. They end up on the ventilator for a long time. They had a hard time hemodynamically, so their kidney function went down. And other things happened to them where it wasn't expected. Their observed rate is going to be much higher than your expected rate. So we didn't have any bad things expected to happen, but a whole bunch of bad things did happen. That makes your observed rate higher than your expected rate and gives you a value greater than 1. When that value is greater than 1, it means that you're not performing as expected. When it's below 1, so your observed rates are lower than your expected rates. And this is where calculating or capturing risk factors becomes very important, because we can't calculate expected risk on patients appropriately if we don't have all the risk factors captured. So if the patient has a really high expected rate because everything, patient is very sick going into the OR or has a really bad history, medical history, but they come out of the OR and they do phenomenal. Everybody's surprised the patient did so well. Their observed rate is going to be very low, and it's going to be lower than the expected rate, which gives them an OTE, or an observed to expected rate, of less than 1. And when you have an observed to expected rate of less than 1, it means that you're performing better than what the STS anticipated you were going to do through our risk modeling and various risk modeling and calculations. So that's why I like Harvest. The reason I like Harvest 1 report is because I can see my site's OTE rates, my OTE ratios across three full 12 months of data, and I can see how we're actually performing. So I can see in 2024, my OTE for this operative mortality is at 0.064. Again, remember, this site was a 3-star program, I think, for operative mortality. So I'm performing much better than what was expected of me. Same thing in 2023. In 2022, I was performing worse than was expected. So what happened? Something I must have done, some type of quality improvement project. We must have done a lot of education. I don't know that my patients are getting healthier, so I don't think that can account for a decrease in my observed to expected rate by that much. But you can see that this site has some improvement over the last 3 years to improve their OTE for operative mortality. This is the like group. Like groups are defined as hospitals that are similar to you in size or volume, and if whether or not they have a residency program. So this has the like group for this hospital as a 0.93, which means they're performing better than expected, but the site's still performing better than their like group, which is great. The region is either the state that you reside in or the region, depending if on the state's volume of hospitals. The region that this hospital is part of performed at a better than expected rate, but the specific hospital is even performing better than their region. And then the STS rate is always 1 because that's the benchmark. You can read odds ratios the same way, and then you can read each of these endpoints, the complications, the same way. The other thing that's in here is the risk-adjusted rate versus the observed rate. Some people ask, we might get questions about why is the observed rate either higher or lower. In this instance, you see that the site's observed rate is lower in 2022 than the risk adjusted rate. And then you can see here, the light group actually has a higher observed rate. The risk adjusted rate is lower. And it depends again on the risk factors that the patients of the patients that are included in the cohort, how the risk adjusted rates versus the observed rates are working. So what this says to me for 2024, the observed rate of these patients was 1.03, but when you risk adjust it, their rate was 1.34. There's more information in the report overview on that. So all similar information down here, and I think we have about 10 minutes left. Let me go over, let's see the benchmark report. I think this is just going to be your benchmark data. If we could look at morbidity and mortality. None of this on the benchmark report, this is not your risk adjusted rate. So you sort of have to take it with a grain of salt, if you will, because it's not risk adjusted. So we're not considering any complications that the patients entered into the operating room with versus what they came out of the operating room with. So you'll see your rates are going to be different here than on the risk adjusted report. When I'm reporting these out to surgeons, I would probably, if I had risk adjusted rates, I would want to report out my risk adjusted rates. And then for things where I don't have risk adjusted rates, I would use this report. And this gets specific. So just specific, these are the endpoints. Any reoperation NQF definition, these are cardiac reoperations, and it just gives your sites data, your light group and the STS group. Again, these are going to be things that some of these are going to be risk adjusted on those other reports like deep sternal infection. But they're not risk adjusted here. It's going to contain all of your other like blood usage information, things you want to use for QI. When you see on this report that there's a dash, it means that there's no data available. So likely for this site, the deep sternal infection rate was 0% for these 2 full years, and then they had a 0.5% in 2024. All right, I'm sure that, oh, and I know what else I was going to show you. On this screen, this is the benchmark screen. So remember we were talking about on that other report, it said how many bad outcomes you had, and then it gave you a number, and then it said multiple morbidities, and it gave you a number of patients who had combined multiple morbidities. But it was really difficult to tell all your patients that had, and I think this is how I do it. Hold on. I might be wrong. It was hard to tell which patients had the bad outcomes. I think if I hit see details, yeah. So on this report, if I just want to see all my patients that had prolonged ventilation, for certain, not, guessing, oh, which patient is in my multiple morbidities tab and which patient's in my prolonged ventilation only tab. I'm talking about the quality ratings details report. I would go to this report, which is my benchmarked report, and I can click on the box and then go up to see details. And the cases that fall into prolonged ventilation are going to come up here. So these are cases your surgeons are likely going to be interested in. It's easy for you to pull up the list of cases from here that includes all of those patients with your patient ID and record ID number. So that's where I would suggest getting that information. Okay, how am I on time, Nancy? And how many questions do we have?
Sorry, I couldn't get off mute. We have about 15
I'm like, oh my gosh, was I talking to myself the whole time?
No.
Okay.
We have 15 questions and 8 minutes.
All right, we'll see what we can do.
All right, so I'm going to take this volume question first because I have this pulled up. So several people were asking about what is a small volume? What does that look like? So it's different for cabbage and valve. So
do you want to share your screen with what you have?
Okay. I can share.
Okay.
Let me That would be much easier.
And this is posted in the national report overview too, I think, right?
Right. It is. It's on page 8 of the report overview in the Akivia library. So you can see a low volume hospital would be 0 to 199 patients for CABG. And then for valves, 0 to 49 would be low. And then moderate, 200 to 399, and high, 400 plus. And then for
Yeah, and
valves,
these are annualized volumes, so yearly volumes.
right. And then we had another question about surgical residency. So a participant is considered to have a surgical residency program if their hospital has a known program. And this is reviewed annually, and it's among a list of accredited programs that specialize in thoracic surgery.
Oh,
So,
thank you.
and then there was another question about where do you find like risk models and endpoints for the star ratings? And so that information, can you see this?
Not
Am I
yet.
still sharing?
No, ma'am.
Ah, yikes. Okay. One moment.
Please hold.
Here we go.
Thank
All
you.
right. So on the website under resources for data managers, and then you would go to adult cardiac surgery database under version 4.2. So we have our risk model endpoint chart. And if you open that up, this is all of the endpoints that are included in your star rating. And this chart gives you your numerator and denominator for the database endpoints. So operative mortality, and then your morbidities, stroke, renal failure, prolonged vent, deep sternal wound, and reoperation for cardiac reasons. And then there was a question about what's included in major morbidity. That would be your stroke, renal failure, prolonged vent, deep sternal wound, and reoperation. So all of that information can be found here. And then let's see, the risk model variable chart. Where is that? Here we go, right above. So the risk model variable chart for each of the risk models, this chart is going to give you variables that are included in the risk modeling for each of the endpoints. So for CABG, if you want to know the endpoints for operative mortality or the risk model variables for operative mortality, you would look under the operative mortality column for CABG, and it lists all of those. And they're marked with an X.
And this is going to go into a question that Pamela asked.
Okay.
So I'm going to jump into that real fast.
Okay.
Where can I find what affects overall star ratings? Well, here you go, Pamela, and this lovely risk model variable chart. And on the endpoint chart, for example, had some locums not performing risk models and possibly affecting overall score. What data points, for example, pneumonia unknown, can cause an issue? So that's a great question, because when these variables that you see on this risk model variable chart are left as unknown or missing, it's going to typically default to the lowest risk possible. So you don't get any, you don't get to account for any of that risk if the patient did have pneumonia if you leave it blank or unknown. The other thing is when we're looking at like lab values, it's going to default to an average value that has the lowest risk. So it's really important to get as much information into the medical record as possible. Some sites, and I think we'll probably talk more about this on future webinars, but some sites have even developed some really nice Epic smart sheets and smart phrases or templated CV surgery consult notes that cover each of the risk model variables right in their consults. So the dictation doesn't go, you don't go without that charting. You're able to do that. Anna, you answered Jackie's question. Grace is asking, why can't the site score be used as basis for the star rating instead of the confidence interval? So Grace, actually, you want the confidence interval to be used because it gives you a broader range to either be a 1, gives you a broader range to be at the highest score possible for your site. When you look at the way that the confidence intervals, if we're looking at 3 stars, your highest part of your confidence interval has to be the lowest point of your confidence interval has to be greater than the STS, where if you just took your confidence interval, which is going to be a higher score, you have less chance of receiving that score. And I'll go into that more in another webinar because I can show you some screenshots of what I'm talking about there. But in essence, the confidence interval gives you a better ability to achieve the score that's most appropriate for your site.
Let's see.
Mary's asking, with the new multi-procedural category, does one isolated category carry more weight than any other than volume? No, not that I'm aware, but Hannah or Nancy, do you know the answer to that? Because I think we've asked Research Center.
Yeah, so the weighting for multi-procedural, so whatever cases are included in your multi-procedural category. So if you're it depends on those cases. So if you're a site that does primarily cabbage, then most of your cases within multi-procedural are going to be weighted like cabbage cases. If you do mostly valves, then your cases are going to be weighted more like valves. You'll have a larger number of valve cases weighted like valves, if that makes sense.
There's 2 questions about not having the multi-procedural report in the benchmark reports. And I guess we might need to talk more about that. Nancy, when maybe you and I can meet more about that.
Yeah, we do. We need to figure that out. All right. We had a question about on the community page where those bar graphs are displayed, if it's possible to display the volume. I don't think that that is possible. That might be something we can also look into.
Yeah, that sounds good. We'll take it back and look into it.
Yeah. And then the cases in what cases are included in multi-procedural. So that is all of your analyzed cases. So it's all of your isolated cabbages, your isolated aortic valve replacement, aortic valve replacement with cabbage, mitral valve replacement and repair, mitral valve replacement and repair with cabbage, multi-valve plus cabbage, and that's it. That's what's in multi-procedural.
And that's it. If
So
you go to the bar chart, this is an easy way to see it too. If you go to the bar chart on the first page and just hit the drop down, it'll show you all of the procedures. And then, in some of the other reports where we have this type of filter, you can see what goes in there.
That's what's included in multi-procedural. I was going to add multi-procedural in there, but yeah. So it's all of those categories. So PROC ID 1, PROC IDs 1 through 5, and then 7 through 10. Let's see. I answered a lot of these. Oh, so can you go over how the new onset atrial fib calculation works? And so for new onset atrial fib, they're looking at patients who have had atrial fib for the first time post-operatively. So for new onset atrial fib, that would be a patient that had post-op atrial fib that did not have a history of post-op or history of atrial fib prior to surgery and did not enter the OR in atrial fib. So it's strictly post-op AFib. So it would be someone who's never had AFib before. Let's see.
And so Heather, why was the multi-procedural category created? What advantage does this extra information give us? It's an overall performance of your hospital with analyzed procedures. So it gives you a larger volume to do a better, like we were just talking about volumes for site performance and how larger volumes increase the understanding of how the site is performing. This gives you a better, larger volume of cases, taking in more cases, and therefore is a better indicator of how your site's truly performing. And then there was a question, can you show where to access the endpoint chart and variable chart again? So while Nancy goes,
I've got it.
oh, I got it right here. Look it. Oh, you could take it. It's okay.
I stole it from you.
It's all right.
Yeah, it's under resources for data managers, adult cardiac surgery, version 4.2, and under additional resources right here.
Thank you, Nancy.
Thank you. I didn't mean to steal from you. You can have it back.
No, it's fine. Take it away.
Did we talk about this question about what the differences are between the O to E and odds ratios?
No, I'm not a statistical analysis, and all I could do is read you what's in the national report overview. But this is my my nursing understanding is that they're they're both very good ways to determine performance of something. In this instance, it would be performance of patients' outcomes or performance of the site. And odds ratios are better suited for smaller. They're both legitimate ways and both valid for all size programs. But if you're a smaller program, odds ratios might be a little bit more specific to you. But they're still pretty close. And we use observed to expected rates in the risk modeling. But read the national report overview because there's more good information in there.
Yeah, that's covered very well in the report overview. Beta blocker project. Carol, wanna?
We're still collecting data in that, and we hope to have a better answer later this summer when the research center has an opportunity to review the data that you all have so kindly voluntarily collected. So please, if you're able to, please continue collecting the data. We hope to give you notice to stop later this summer.
All right, and so back to the atrial fib calculation on your unadjusted report, your participant dashboard, that atrial fib is calculated the way it always has been. That value will just be how many patients had postoperative atrial fib,
No
regardless of their
exclusions.
history.
Oh. Okay.
Oh, when will the surgeon reports be posted?
I'm not sure.
I know they use Harvest One data for that, so hopefully that will be coming up soon. The COVID question, do we still need to be answering that?
I don't know. Yes, we haven't had instructions not to, but we should probably continue it through version 4.2.
We have a couple of folks saying they have found some discrepancies between the participant dashboard and the benchmark report for the multi-valve
Yeah, I would send those into the
Deposit.
STSDB_helpdesk at
Yep.
sts.org. And I'll put that email in the chat.
Let's see. What else? Let's see. In the star rating report, it shows our hospital is having 2,000 plus cases. This does not seem accurate, but when we look at risk adjusted, our multi-valve and multi-valve plus cabbage cases are accurate.
I would send it into the
Yeah.
STSDB_helpdesk. They'll probably have to ask you more information and want some screenshots. So that's the best place to send those questions into.
Michelle just started collecting the anesthesia data. And
Yeah, maybe we
know
could do
what's
that in the next monthly webinar or one of the other next webinars where we don't have education planned for right now, so I can go through that report. I have to find a site that.
So another about a fib on the unadjusted report, we have STS 2024 26.06. Is that
Let
a
me,
percent of all?
yeah, I think that is. Let me pull up the report. Hold on. And I think we got to get going here pretty soon.
Yeah.
I'm just going to go to isolated cabbage. And then, Grace, is there a way to get data for elective complex cardiac surgeries requiring CPB and FFP supplementation with the data we submit to STS? That again, please submit that, not again, I didn't tell you this yet. Please submit that to the STSDB_helpdesk at sts.org as well, Grace, and they'll be able to provide some guidance on that. And then Sheila, do different morbidities carry different weight values for risk adjustment? Yes. Different, you mean comorbidities or morbidities? You'll have to clarify, Sheila, on that one. Yeah, let me pull up this AFib report. I should have done a smaller time frame.
On the participant dashboard, I believe that the denominator for atrial fib would be from the patients that had a postoperative event or complication.
I think the percentage is based off of the post. Yeah, right. That's what I was just going to say. And then we're going to add a column in here that shows. Do you want to explain that, Nancy, since you're
Yeah,
going
so
to lead that one?
on the participant dashboard for postoperative events, the percentages are taken from the numerator is the occurrence of the event, and then the denominator is based on the number of cases that had an event.
Right. So when it's going to be this in-hospital post-op event, other than surgical site infection, equal to yes.
So the site had 1,192 cases, but only 377 post-op events.
Yeah.
So then your post-op events, the denominator would be 377.
Right. So when you look at this value is 21 out of 377, that would be 5.6% of post-operative were re-out for bleeding.
Yeah.
So when you look at the AFib events, it's the same, calculating it the same way.
And we are working on an enhancement for this report to give you both calculations, one on your total number of patients, and then we'll continue to have it calculated this way.
So when I'm looking at this site, for example, what Nancy just said, This site had 298 patients out of their 377 patients. Where did it go? 298 patients out of their 377 patients gave them that percentage. But when I want to find out of all my patients, I'll take that rate of, I don't know, 298 out of the 1192. 298 out of 1192, and it's 25%. So this site's AFib rate, which remember we're talking about, that's in this report, it's any AFib, anytime this field was coded yes, is 25% for their total population. In the definition though, in intent clarification for AFib in the training manual though, are they supposed to exclude patients from having being an AFib at the time of OR entry from this? This is new onset this is
That's,
newer onset or recurrent.
If you're
this is,
if you're an atrial fib going into the OR, then and you have AFib post-op, then you don't code that as an event because you entered the OR in AFib.
But for patients who had a history of AFib, were not in the time of not in AFib at the time of OR, but go back into AFib after, then you code this as a yes as well, right? So patients who never
Yes,
had AFib,
yes,
or patients who had AFib but were not in AFib at the time of OR entry.
correct.
Okay. So it's
that's
actually
correct.
new onset or recurrent and excludes patients who were in AFib at the time of OR entry. Okay.
Yep. And then we have someone asking about the audit. So I believe those audit letters are going out very soon.
Yeah,
So
that's the plan.
be looking for that. And then Sheila was clarifying, she was talking about the morbidity section of the star rating report.
Yeah.
Um,
So for the, oh, go ahead, Nancy. I'll let you. Sorry.
Oh, I was just gonna say, she was asking if prolonged ventilation, deep sternal wound, those those morbidities were weighted differently. And they're not, it's just a one or none. Right? Any
Yeah,
or
that's
none.
right. Just like a morbidity happened or didn't happen.
Yeah.
It doesn't matter more than one. All of them, it's the same. Something happened or it didn't happen.
Yeah, and it's all weighted the same.
I would send that, Leanne Jackson, I would send that question
Okay.
into the help desk, please.
All right. That's all we have.
Okay.
Thank you, Carol.
Yeah, hopefully it
Was
was
it
helpful.
very good overview. And thanks for your questions. If you have anything that you need answered, you can send it to the help desk. Carol's got that in the chat. Thank you for joining. We appreciate you.
Thanks, everybody. Good job. Thanks, Nancy.
Thank
Take care,
you.
everybody.
Thanks,
Bye.
Carol. Thanks, Nancy.
Bye,
Bye.
everyone.
Bye.